Hey all, now we're gonna learn about complex regional pain syndrome or CRPS. The abbreviation for complex regional pain syndrome is CRPS. It is characterized by pain that is greater than would be expected from an injury that caused it. It usually affects the distal limbs or the lower limbs, but it is also seen in the arms. The pain is severe, it is regional and not dermatomal, not according to the distribution of a nerve. There is swelling, there is decreased range of motion, there is vasomotor instability, skin changes are seen as you can appreciate in this picture. This is the image of a patient with lower extremity CRPS. Patchy bone demineralization is seen. If you do an X-ray of this foot, you will find patchy osteopenia in the X-ray. Frequently follows a fracture,
what is the
soft tissue
pathogenesis
injury
of
or
CRPS?
CRPS develops 4 to 6 weeks after trauma. It presents with clinical features that can't be explained by the initial trauma. Diagnosis of CRPS is a diagnosis of exclusion. When no other condition can explain it, you assume that the diagnosis is CRPS. Bone scintigraphy is a confirmatory test. You will see increased uptake in the affected limb compared to the normal limb, and that will confirm the diagnosis of CRPS. The most common inciting events leading to CRPS are fracture, crush injury, sprains, and surgery. No precipitating factors are, however, identified in 10% patients. So 10% patients just get CRPS without any event leading up to it, because minor injuries like sprains are sometimes. There are two types of CRPS. Type 1, in which no evidence of peripheral nerve injury is present, and it is the most common type. It was earlier known as reflex sympathetic dystrophy, and it happens in 90% of the CRPS cases. Type 2 was earlier called causalgia and refers to cases in which peripheral nerve injury is identified. Now this is a beautiful mnemonic which will help you remember this condition. It's an acronym STAMP, which stands for sensory, trophic, autonomic, motor, and pain. So these are the major changes that you see in CRPS. The sensory changes are allodynia, which means pain to light touch. Hypo or hyperalgesia means increased sensitivity to pain. Hypo or hyperesthesia means increased sensitivity of the skin in general. It happens in all types of neuropathy. Then trophic. The trophic changes that are seen are skin, hair, and nail changes. There may be increased hair growth, skin may be broken. Autonomic changes, swelling, edema, sweating. You can see sweating, swelling, the redness. Motor changes, weakness, contractures, atrophy, and pain. And the temperature is going to be higher because of
Pain in
inflammation.
CRPS is the most prominent symptom,
And it's really debilitating. It's severe burning, stinging, and tearing sensation that is felt either deep inside the limb and maybe superficial in some. The pain is continuous and undulating, and it can be paroxysmal too. It is worse at night and exacerbated by movement. That's why there is limited range of motion too with CRPS. What are the sensory abnormalities seen with CRPS? There is hyperalgesia, allodynia, hyperesthesia on examination. Sensory disturbances are usually distal in the limb, sometimes in a glove stocking pattern. Swelling that comes and goes, temperature of the affected hand or foot feels hot to the touch, agony out of proportion, redness or purple discoloration, tremors are seen. It's hard to treat CPRS if it's diagnosed late, so you have to start now with neuropathic meds like gabapentin, pregabalin, opioid medication, and workout, physiotherapy. That's helpful in managing CRPS. Motor abnormalities seen in CRPS: functional impairment related to pain. Impairments typically manifest by a reduction of complex muscle strength in hand grip or during tiptoe Standing. Limb movement may be
Autonomic
limited by
symptoms
edema,
like
pain, or
difference in
contractures.
skin temperature, skin color, sweating, edema compared with the unaffected side, as given in this. Trophic changes like increased hair growth, increased or decreased nail growth, contraction, fibrosis of joint and fascia, and skin atrophy may be seen in CRPS. How do we diagnose CRPS? It's based on the clinical features as determined by history and physical examination. Diagnosis is suspected in the following circumstances: symptoms like pain, sensory changes, motor symptoms, autonomic dysfunction or trophic changes developing after limb trauma within 4 to 6 weeks, symptoms no longer fully explained by the initial trauma, symptoms affect the distal limb, go beyond the region involved in the trauma, or extend beyond the territory innervated by a single nerve or nerve root. That is, they don't follow a dermatomal fashion. It extends beyond the territory, which affects a territory innervated by a single nerve or a nerve root. Which is used to diagnose CRPS. So how do you use this criteria to come to the diagnosis? First, there is pain that is disproportionate to any inciting event. The patient had a small sprain and now he has such a swollen foot. Then at least one symptom reported in at least 3 of the following categories. So there is sensory, vasomotor, pseudomotor, motor trophic. So in 3 out of 4 categories there should be at least one symptom. You already know these symptoms, but you need to remember the number 3 out of 4 here. At least one sign at time of evaluation, at least 2 of the following categories. The name of the category heads is again the same, but here you need 2 out of 4. Okay, and no other diagnosis can better explain the symptoms and signs. Then you know that it's a diagnosis of CRPS. Now, imaging is usually not needed in this. It's only done when diagnosis is doubtful, because it's basically a clinical diagnosis. So as you can see, there'll be increased radionucleotide uptake or radiotracer uptake in the limb which is affected by CRPS. The limb is affected by CRPS and it has greater radiotracer uptake. Plain film radiography is often demonstrates patchy osteoporosis, but its sensitivity is pretty low. Autonomic testing like resting sweat output, resting skin temperature, quantitative pseudomotor axon reflex tests, they are usually not done. But sometimes experts advocate serial measurement of skin temperature based on the evidence from one small study that a 2-degree difference for the affected versus unaffected side was supportive of the diagnosis of CRPS. Now, what interventions are appropriate for the patients with CRPS? Patient education, physical therapy and occupational therapy as quickly as possible. Psychosocial assessment to determine whether psychosocial and behavior management is necessary. Symptomatic pain management, beginning with low risk pharmacotherapy and maybe higher drugs if these don't work. Now, this slide is about psychosocial and behavior therapy. Patients who have pre-existing or suspected psychologic or psychiatric issues often develop even worse symptoms with CRPS and they need psychotherapy. Now this is a small summary slide about the treatment of CRPS. You start with non-steroidal anti-inflammatory drugs or NSAIDs, then an adjunctive medication for neuropathic pain like gabapentin, pregabalin or a tricyclic antidepressant may be used. A course of bisphosphonate treatment in patients with CRPS and evidence of abnormal uptake on bone scan is often helpful because there's abnormal uptake on bone scan, there's osteopenia, so bisphosphonate will help with that. Topical lidocaine cream or topical capsaicin cream is also useful in some people but may be discontinued if there is irritation and there is no benefit after 3 to 5 days.